So.
Like that.
No, you go over there. Yeah.
All right, we'll go ahead and get started. Hi, everyone. Thanks for having us here today. I appreciate I feel like I don't even need this. The 5 of you showing up. So we'll be speaking with you today about lethal means counseling 101, so how to approach that within the emergency department. I'll start with some introductions. So my name is Bijan Katabchi. I'm PEM faculty at Children's Hospital of Philadelphia, and I did some specialized training in emergency psychiatric care. Mic for yourself.
I'm probably loud enough. Hey, everyone.
Yep.
Yeah, this is great. Thank you. Hey, good morning, everyone. I'm Sophia Chaudhary. I'm also a PDR physician at Emory University with Children's Healthcare of Atlanta, and I have been leading the lethal means counseling initiative in our pediatric ER.
Hi, everyone. I'm Susan Duffy. I'm also a pediatric emergency physician at Hasbro Children's Hospital in Providence, which is part of Brown. And my area of work is in implementation of children's mental health programs in the emergency department.
Good morning. Oh, we finally have more people than speakers, so that's great. My name is Eric Fliegler from Massachusetts General Hospital. I'm also pediatric emergency medicine and a health services researcher, and for the last 13 or so years been focusing on firearms and understanding how to prevent injuries associated with them.
Hey y'all, I'm Lauren Hudak. I'm representing the adult side, so I'm an adult emergency medicine doctor in Atlanta, so I work at Grady, and most of my work in firearm-specific research and education has been working with gun shops and counseling gun owners about safe storage decisions. So yeah, thrilled to be with you guys. Thanks for, Sono Games is really hard to compete with, so thanks for coming.
Awesome.
We should have dressed up.
I know, I should have got
Now, there were some pretty cool costumes that I saw. We have no disclosures of conflicts of interest to resolve. So what we would hope to provide you with today is help you understand the epidemiologic trends in pediatric and adult suicide and how they're presenting to the ER, as well as recognizing the critical role of emergency clinicians in providing lethal means counseling. Understand the efficacy and feasibility of providing this, that it's something that is very simple to implement at your own institutions, as well as giving you the tools to and strategies to implement that where you work. So we'll start by discussing the prevalence of suicidality and its relevance to EM. So youth in the US are struggling with mental health. 1 in 5 will be diagnosed with a mental health condition at some point during their childhood, and that translates to roughly 7.7 million children. Unfortunately, only half of them are receiving the necessary treatment. Youth suicide is now the #2 cause of death among all children in the US and has been for over the last 10 years. And is steadily increasing by several hundred each year, most recently in 2021 reaching nearly 3,000 children. Unfortunately, now over 50% of these deaths involve firearms. If we look at it broken down by, suicidality broken down by sex, this is data from the Youth Risk Behavior Survey. It's a nationally representative cross-sectional sample that's distributed to high schoolers every 2 years. Some of the things they ask about are suicidality, drug use, and sexual behaviors. So if we look at adolescent females, 30% seriously considered suicide and 13% actually attempted. Males are slightly less. We're about 1 in 7 seriously considered suicide, and 6.5% actually attempted suicide. Unfortunately, sexual minority youth, so those that identify as LGBTQ, the YRBS did not ask about gender identity, so we don't have data regarding transgender students at this time. They are higher across the board, so whether it comes to suicidal ideation, planning, or attempts, universally higher than all of their heterosexual counterparts. In fact, over 20% of sexual minority youth attempted suicide within the last year. There we go. So why should an emergency clinician care about this? Well, to start, nearly 1.5 million youth, their only point of healthcare contact is the emergency department. And visits for youth among all emergency departments in the U.S. Have increased drastically over the last 10 years. One study found that in 2011, 7.7% of youth visits were related to mental health, and that increased to 13% as of 2020. What that translates to is going from 4.5 million visits each year to in 2020, there were 7.5 million visits for peds mental health specific reasons. One study that a little bit older, from 2007 to 2016, actually found that during that time period, there was a 329% increase in self-harm related visits to all EDs throughout the US among children. So over 80% of kids that have attempted suicide are not identified in the PCP visits in the months preceding, which is especially unfortunate because even though they have these touch points with their primary care doctors, they're not always identified. However, where the ED comes into play is that over 50% of these youth will have had an ED visit at some point in the year leading up to their death. So, we'll discuss adults briefly.
Hey, everybody. So this is also pretty, as you guys know, especially in our middle-aged to elder adult population, suicide is a huge deal. And so I did a snapshot of just 1 year of data here. So in older adults, you can see from 2021 to 2022, it's increased. A small reduction in the youth over that 1 year period, but as you can see over time from the prior slides, it's really been going up. It's the 8th leading cause of death in middle-aged persons, with men 75 and older having the highest rate. Specifically, veterans also have very high rates of suicide. And so most of this data trends you can see over time through the decades, which thanks Eric for the slide for that. Adult suicide, just to help put the adults in context as well, because we had some teenage and youth data. About 12.3 million seriously thought about suicide in 2021. 3.4 made a plan, and then 1.7 actually went through to attempt suicide. And then the real important thing here, and especially with us as emergency physicians, is thinking about the time when they're thinking about suicide and planning to actually going through to completing suicide. It's usually a pretty impulsive decision, very short period of time when people make that decision and then go on to attempt. And then also another misnomer is folks think that, well, if they don't, find this one way to attempt, they're going to go on and do it another way. But in fact, actually 90% of folks do not go on to die by suicide, even though they've attempted. And so intervention is really critical, especially when that decision to attempt is being made. And so if we can make time and space between that really helps us save lives. And just to show the data on what modality of suicide ends up going through for completion, we see that firearm is far and away the most utilized method in attempts and completions, in completions. So I think we give this over to Eric. Yeah, there you go. So we're going on to the overview. Yeah.
Good morning. So I want to take a moment and talk about lethal means counseling, which is kind of the whole point of why we're here today. The framework of lethal means counseling is the idea that this is an opportunity for us to talk to families who have some sort of crisis, whether it's in the pediatric world with their child in crisis or an adult who's in crisis, and to help them think about how do we reduce the risk that they may actually die by suicide. That is the essence of what we're talking about. To perform this, we need to kind of help families understand what are the risks associated, and most importantly, what are the steps that they can take to try to reduce the risk that their loved one is actually going to die. And so I'm going to go through kind of talking about the physical access to this, and then think about like the opportunities for having access to these lethal means. So first I want to kind of talk about the ways people end up dying. So this is a graph on the right side that looks at what's called the case fatality rate. So in other words, if somebody tries to die by suicide and they use one of these methods, what is the likelihood they're actually going to die? And so let's take a look at poisoning first. So it turns out poisonings, which are the #1 way people attempt to die, are actually very difficult to die that way. And there's a number of reasons for that. 1, a lot of people don't know which medications are the most lethal. 2, the body has really good mechanisms. It has a great way of making ourselves throw up. But 3, and probably the the most important thing is when somebody tries to take an overdose, they have the opportunity for regret. They have the opportunity to think to themselves, I need to let somebody know, I need to get myself to a hospital, and we as providers can do something about it. Firearms are the exact opposite. Firearms are very, very impulsive typically when they're used in suicide, and their lethality is at least around 90%. And so when we think about people when they're going to die by guns, as already was said, with kids, it's over 50% of kids, and in adults, it's about 65% die by firearms. If they use that gun, they're almost universally going to succeed. And this is something to help people think about when we talk about what is the counseling we want to provide from a safety perspective. So what do we know about people, kids in particular, who die by firearm suicide? So it turns out when we look at them, and this shouldn't be too surprising, those who die by firearms are more likely to live in homes where firearms are available. Just kind of let me reemphasize that. It's that availability of the gun in the home of the individual who kills himself that is the problem here. There are people who have suicidal thoughts no matter whether they live in a house that has a gun or not. But whether they actually die by a gun is so much to do with its availability, in particular in their home. At least 65% of children and youth who die by guns, it was owned by their parents. So it turns out, in particular, that the way those guns are stored makes a huge difference. So, a lot of people in the United States in particular keep guns in their homes today because they say they want it for the safety. They want to protect their home. And this is something we need to kind of address as an important element to say, we recognize you're looking at the safety of your home, but the safety of your children is actually the paramount issue that's going on here. So those who store their guns loaded and unlocked, which is typically, in that dresser right next to the bedside, those are the most lethal opportunities for children and youth to get a hold of those guns. If they can store them separated from the ammunition, where the gun and both the gun and the ammunition are locked up, that reduces the risk of somebody. We used to call that secure storage or safe storage. In truth, that should probably be called safer or securer storage. In other words, it's not a guarantee it won't happen, but it's definitely a step in the right direction. We also know that actually adolescents who have known mental health problems are more likely to actually live in houses with guns. This is more of a fluke than anything else. I don't think it has to do with the firearms themselves, but these are at high risk, and often the families don't recognize that. So let's talk about the lethal means counseling associated with poisoning. So it's the third leading cause of suicide deaths, but it is actually what most of the time people are going to use, and 98% of the time, fortunately, they'll survive. Among adults who do overdoses, they are frequently using more lethal types of drugs, opioids, barbiturates, antidepressants, anti-diabetic medications, aspirin, alcohol being combined, we all know it makes it more lethal. Kids tend to just grab whatever is available. And what parents typically don't think about when it comes to over-the-counter drugs is things like Tylenol are the ones that have a high lethality. Of course, not in the immediate period, but if it goes unrecognized after 48 hours, the dose is high enough, you're going to end up with liver failure. And so this is an important opportunity to talk to parents about that because they don't really think about these things necessarily. These are the medications their husband is using, that their child is using, and they're not thinking about it from a poisoning perspective. So when you talk about these medications with the families, the really key thing is to give them the opportunity to think about, well, what am I now going to do? Because I have to have these medications in my house. I have this conversation all the time with families, and one of the things I recommend is you can go to Amazon or the Container Store or wherever you want and get small boxes that have built-in combinations. I used to recommend basically like a tackle box like you'd use for fishing, and you put an actual combination lock. You don't even need to do that. You can readily get inexpensive boxes that have combinations built into them. In our own house, because we've had to deal with mental health problems, we have a variety of boxes in different places because you don't always want to go upstairs to the closet in the lockbox to get your Tylenol, and we do that. We talk about the number of accessible pills. So even if you want to have Tylenol and Motrin readily available, don't have a bottle of 100 in your kitchen. You can have a bottle of 10 and keep it more limited like that. The blister packs, which require you literally to pop out one pill at a time, have an advantage in terms of reducing risk and having less numbers. And then, of course, everybody has medications at home that they're no longer using. And this is an excellent opportunity to get rid of those medications and encourage people to think about it. Doing lethal means counseling is something that we're all able to do, but I think having a little bit of training, especially around the firearms, is a really important thing. And it turns out there are many organizations that have developed wonderful programs, and I will tell you, as an individual who's had these conversations going on for years, I've gone through these programs and learned so much myself about how to kind of tweak my style. The CALM program, Counseling on Access to Lethal Means, American Academy of Pediatrics, from the American Foundation for Suicide Prevention, all of these organizations have really wonderful resources that you can listen to. As far as kind of how do we increase this opportunity, so I'm sure we've all taken care of patients with mental health problems, and we've probably all at the end of the day sometimes had that patient, you're like, I didn't have that opportunity. And it's a missed opportunity for us to do this. Or maybe we're thinking the psychiatrist is going to take care of it. Or the resident was the person who took care of the patient. And me as the attending, what is my role in kind of furthering these conversations? But to try to increase that, make sure that we don't miss this, having checklists built into the electronic medical record is a key thing where you're actually saying this is what I have done as part of that. When it comes to the firearms, this is a very different area that we need to work on. So in terms of firearms, what is going to happen, and you need to, and the panel's going to kind of go through more detail in this. You do need to understand the reasons for why families have it. You do need to take a respectful approach, but most importantly, once you help them understand why you are concerned about the child's risk, you then need to have opportunities for them to think, well, what do I do? So there's a variety of things that can be done to help families. So getting lock boxes and having discounts available to them, it's really important. Reminding families that some of the lock boxes, especially some of the more sophisticated ones, can have biometrics that can recognize fingerprints or codes that can be accessed very quickly. There are cable locks, which are very inexpensive and are frequently given out in emergency departments and primary care offices. One of the challenges is some of the families don't really love these, and they're a little bit awkward to use, but you have to kind of recognize that balance of cost and availability. And then we already talked about medications. This last thing on here is called Lock to Live. This is a fascinating piece of software which I'd really recommend people take a look at. What it allows you to do is it's from the family's perspective. I have a loved one who I care about, and it actually walks them through the steps of how they can protect their family member and with regards to guns. It is very well written. It is written at a low education level, so it's very accessible, and something I would urge you to take a look at, and you can just make as a recommendation to give to families. It could readily be put on printouts as well. So, talking to families about the risk associated with their child, especially those who come in with mental health crisis. Strategizing with the family. We all know that when we just tell people do something, quit smoking, that's not an effective mechanism. We really need to talk to them, spend the time to say, what do you think is going to be the best way to protect your child? Creating a safe environment to helping understand that. Appreciating the perspective of gun owners. Most gun owners really do want to be safe, responsible, feel that they've done a good job with this, and we need to recognize that, give them the credit they deserve for that, but then kind of move the conversation forward to think, well, what are the risks associated for your child or loved one? And then talking about the resources. I think this is where I transition over. Laura?
So all the things Eric mentioned for pediatrics is so relevant also in adult populations as well. So their reasons for ownership is so critical. I'd say the ones that are owning for personal protection can be some of the hardest to counsel for, and so you have to kind of work with them when they're acutely at risk for suicide, out of the house when they're in that acute crisis. So that's always the emphasis first, but then sort of scale it back with the goal, if at minimum being locked, loaded, ammunition locked, and stored separately. So that's kind of our minimum goal. If you can, lethal means counseling has us try to have folks get it out of the house in those acute settings. We also have biometric lock boxes that folks for those quick access self-protection. But again, if that's the acutely at-risk person, you're going to try to not emphasize those sorts of storage devices. Or if there's another trusted family member, getting them to be the person that has access to all of those codes. So if the owner, again, is at risk for suicide, you're going to want to change that code and give it to a trusted family member in all cases. So the biometric lock, which would be the fingerprint or the quick access finger. We should have brought our safes, but you can do that on the plane. The codes, but those you'll want to have a family member or another trusted person be responsible for those. And again, voluntarily out of home storage is sometimes acceptable to folks. They sometimes don't want their family members to know about it. So things like gun shops, shooting ranges, police, a temporary transfer transfer is another issue too in certain states where you'll have to register or have a background checked in order to get those temporary out-of-house storage options. But again, those are all things that you can work with your patient. And so it really is a dialogue with the patient to figure out what works for them and then really try to push them to make some safer choices. So you're going to, like we mentioned, want to be knowledgeable of your state laws. So in Georgia, there is a voluntary, there is a 24-hour transfer background check that they'll do if you try to give it to a gun shop or a shooting range. So it varies widely, as you guys know, based on where you live in the country. So also ERPOs, those are ones where extreme risk protection orders are in place where healthcare providers can, appeal to get folks firearms taken away from them in acute crises, such as suicide or harm to others. And so I want you guys to check out these resources. Hopefully, I think they're providing these slides to you guys, but if you want to take a picture, you'll at least be able to get some of the information here about what your state laws require you to do, and also, what you can advise your patients in real time to know what options are available to them. So I think we're on to the SAM. Get to this. Oh, no, not.
Okay, so let's just talk very briefly about, do these interventions actually really work in the ER? What is the evidence around that? I'm just going to highlight a few studies, both from the pediatric and adult populations, to kind of help bring that point home, that these are actually really effective interventions and that they do result in beneficial outcomes. There we go. So this first study is one of the pediatric studies that came out in 2020 by Miller and the rest of his team. And they actually did one of the first multi-center pediatric control trials in the pediatric emergency departments, where they had trained behavioral health clinicians engaged in lethal means counseling. And that's something to consider if that's a resource that you have. So as we go through the slides with evidence, just thinking about, where in your model in the ED would this fit? And that specific training that they actually received was an adaptation of the CALM training that we've referred to earlier, and that's typically universally available and free and online. And they did an adapted training where they did in-person workshops. And then they also offered, as a part of their lethal means counseling training, they offered to the families free medication lock boxes and then also gun lock boxes. They followed up with them, their study team followed up with them after the behavioral health clinician gave the lethal means counseling as part of their routine care with these added resources. And then when they followed up, they found that at least twice as many families were storing their firearms appropriately, locked and per the recommendations as before the study intervention, and 3 times as many families were storing their medications locked. We've actually trialed something similar to this in our southeastern pediatric ED and just piloted at a much smaller scale, and actually out of the 50 families that re-enrolled, 10 of our families actually also stored off-site after our intervention. And so this is effective in different demographics and different populations. This particular study was done in the West. Another particular study, this was conducted by the USPAL group in 2021, and this was a randomized control trial in a freestanding tertiary care children's hospital, both in their emergency department and their psychiatric unit. And similar to the prior study, they involved parents that were presenting with youth with an acute behavioral health complaint, and they had trained research assistants that were engaged in lethal means counseling. And after their routine care that they received from their behavioral health team, these research assistants came in, engaged them in lethal means counseling, offered them either a free or low-cost firearm safe storage device, and then provided education via video on device use. So again, it gives you another option for how to provide education that may be more flexible and adaptable. And then they had these families sign a firearm safety pledge. This study was their randomized control trial, and since then they've implemented it now on a larger scale. What they found was when they followed up on the specific outcome of triple safe storage, so families storing their guns locked, unloaded, with the ammunition stored locked and separately, that at both 7 and 30 days, when they're comparing their observation phase to the intervention phase for those that received free lock boxes to those that received reduced cost, that offering free firearm storage devices resulted in a much higher rate of families storing their firearms locked. And so they saw that that was effective for both a reduced cost and for those that received free devices, but ultimately those that got them at no cost were the most effective. And moving now into the ER adult population. So this particular study was done by the Mueller et al. Group, and what they did was a quality improvement study in an urban academic ER where they enrolled patients that were presenting with an acute suicidal crisis that were going to be discharged. And they trained personnel that were non-clinical to engage in lethal means counseling and to offer free gun locks. What they found was that amongst the 166 family adult patients that they enrolled, about half had access to a lethal means. So whether that be medication, knives, or firearms. And in follow-up, when they contacted them a few weeks after receiving lethal means counseling from the ED, about 75% of them had a storage plan for their lethal means. So that truly shows that, you know, these patients are listening and that hearing this in the medical setting is effective. So now let's move into the approach. We're going to kind of do a little bit of a deeper dive from what Eric has talked about a little earlier, and I'm just going to go into the very beginning of it. So when you're approaching families of a youth patient that you think would be eligible for receiving lethal means counseling, there's a couple of things that you want to keep in mind. First, you want to introduce the topic so that it's not a surprise, and maybe say something to the effect of, you know, many children and teens struggle with mental health. This could potentially be a family that you're seeing for either an acute suicidal concern, or they're there for depression, or potentially they've been flagged as having mental health concerns. And then you want to kind of explain the importance of why this topic is important. So something to the effect of, last year, 1 in 5 teens considered suicide, and 70% of them have gone from thinking about it to actually attempting in less than an hour. And then lastly, you're going to want to provide guidance on what they can do. And you can say something to the effect of, you know, medications, so that they understand the varying risks and the degree of risk. That medications are the most common means of suicide, but firearms are the most lethal or the most deadly. And that we know that securing or removing dangerous items in the home can reduce the risk up to 80%. Pass on to Sue.
I think, why is this an emergency department issue, and why is this our issue as emergency department physicians? The majority of patients who are suicidal go home and are discharged and are at high risk for completion of suicide within 6 months of discharge from the emergency department. So this is our population. And if you think about what can we own, I think there's a lot of frustration among emergency physicians about, what can I do for this population? Well, I think this is the thing that we should own, is emergency physicians, and it's around lethal means counseling. But it's a skill like everything else, and it requires some training and thoughtfulness and approach in the right manner. When we talk about it, it has to be a collaborative conversation and we have to understand why it is that our patients and our patients' families own guns, in order to collaborate with them to keep their environment safe. And I have learned to approach, and through training, of not asking, do you own guns, but instead, how do you store your firearms is the question. And then it gives the family an option to say, I don't own firearms. I live in Rhode Island. The firearm ownership is low, but in other parts of the country, that's not true. So when we talk about options for storage of firearms and around safety, it really has to be about a collaborative conversation and an explanation that temporarily it may be safest for this patient to store firearms off-site or out of the home. And there are a lot of options, as Lauren had talked about. There's gun shops, there's shooting ranges, police departments, which many families are very reluctant to engage in. There's storage facilities, there are pawn shops, and then there's neighbors and friends and family. But those all involve other issues. There may be costs involved, which is something that a family has to think about. And Lock to Live takes families through that step. I actually have families do it in the emergency department and link on to that. Some require background checks, and some have limits to storage. At the minimum, the emphasis is really on triple safe storage if a gun is going to stay in the home. If you're unable to remove the firearm for whatever reason, in a non-judgmental fashion, locked, unloaded, and the ammo locked separately. But for those who use guns for safety purposes, then a lockbox next to the bed with biometric locks is probably the safest, yet there's a cost involved. And then having the conversation and being prepared for families who actually, and patients who actually think about safety to begin with, saying, my kid does not know where the guns are kept. Well, there are studies that show 75% of kids know where the guns are kept. And that's why it's important to have conversations with adolescents separately from families. And also think about who comes to emergency departments with kids. It's usually a mother. They're not typically the gun owner. So that be thoughtful about that when you're having those conversations, but also a separate conversation with an adolescent about their own access to guns. And then my child was educated about firearms and saying that is so wonderful that you emphasize safety and that your child is in a program. But that really doesn't prevent in an impulsive decision making, that is not going to impact whether or not they're going to choose to use that firearm if it's available, accessible, unlocked, and they know where the ammo is, even if it isn't unlocked. But every one of those 3 steps, even if provides a barrier, because suicide is really mostly a transient event in an adolescent. And then they're doing this to get attention. I think we all see a lot of adolescents and children and young adults who express suicidality, and it's sort of sorting out. That's a whole nother topic. But know that 80% of children who died by suicide had warning signs, did make statements. So those statements have to be taken seriously. And then, that's you, Lauren.
So, it's a little different with adults, as you guys know. So it's, they're the person at risk. So sometimes engaging that trusted family member isn't always feasible, but you're acknowledging, hey, you're a responsible gun owner. I acknowledge and respect your right to own. But right now, you're in acute crisis. Like, what can we do to get you back to that level where you were, and you can be a responsible gun owner again. But right now, it's unsafe. What do you think? And sort of acknowledge with them. And then very critically, getting another person involved. So whoever their most trusted person is, it can be, if they're a veteran, another veteran that they're close with that maybe has struggled similarly, adult child, neighbor, anybody that person could feel comfortable disclosing with in order to just engage that person in safety planning is really critical. And seeing if they can do it right now with you, and sometimes I'm a night shift ED doc, so all I do is nights, so it's hard to engage family members, in the middle of the night. But I do try, and I try to see if there's someone that would come in and help be that trusted person like it is in adults with pediatrics. Again, emphasizing their safety, that this isn't about you being, we respect your right to own, and especially in Georgia where I work, everybody, even half the physicians all are firearm owners too, it's really focusing on safety. Like right now it's not safe, and try not to be paternalistic with them about that. It's helping kind of engage in that patient-doctor relationship in a way that's respectful and also very dialogue. They'll want to work with you. They want to help make safe choices for themselves. And especially if they have children, a lot of times that's a good way to sort of engage with them in order to help emphasize that added safety. So, all right, so helpful resources. I think this is Susan again, yeah. Okay.
I think we covered that there are resources for training. I would recommend training for all of us. And both the COM and the American Academy of Pediatrics has a Counseling and Access Lethal Means that's a 2-hour free to everybody. All of these are free resources. So I think they're worthwhile. A good use of 2 hours gets MOC credit for pediatrics and CME. I think it's in emergency departments, we need to have standardized care, and we can't do things in isolation. So I can one-off talk to families, but unless there's systems set up so that it makes, and we've got a lot of systems that we follow, this is not going to be done routinely. So if you think about it and take home, what are things that I could set up in my emergency department that have been shown to be very effective? That includes incorporating screening tools and counseling into routine care. And so there are EMR checklists, smart phrases, there are best practice alerts within Epic that can be built that trigger for a certain population of patients, anybody who's got a mental health diagnosis, or you could argue that it should be done on everyone, but to do a checklist of going through with a family at discharge about lethal means. There are a number of programs throughout the country that offer safe storage for going home, including lock boxes, the very cheap cable locks, medication lock bags. There's also aids to support. The Lock and Protect was a study done by Jonah Sarno and her group. She's a very, very important suicide researcher. It's shown to be quite effective, and it is an online tool. Check out Lock to Live. It's definitely, once you see it, you'll say, oh, I got to figure out some way to incorporate it. I've incorporated a QR code into our discharge so that families can sit and take their phones and do a QR code. There are a number of discharge resources that are readily available to build in, including the American Academy of Child and Adolescent Psychiatry. Means Matter from the Harvard School of Public Health has recommendations for families. And then there are a number of hospital systems that have set up programs, such as Cohen's Children in Long Island has a hospital checklist that goes discharged. And then a suicide safety plan is another resource, which I say the majority of emergency physicians feel like that's beyond the scope of what they're going to do because it does take skills, but built into that is lethal means counseling. And then the other sort of great resources have to do with coalitions that have been through gun owners, firearm associations, and the American Foundation for Suicide Prevention has collaborated with a number to turn out some great resources, including videos that you can incorporate, YouTube lines or QR codes into it for families.
So just briefly, we wanted to kind of go through some cases. We're not going to role play these out, but we just kind of wanted to discuss some of these. Yeah. I did not volunteer. You're not going to add Oscar to your award repertoire? No. So I hope that this presentation thus far has given you a good understanding of, one, that lethal means counseling is important for an ED clinician, as well as the fact that this is an evidence-based intervention that is applicable to both adults. And so if you already have that in your institution, you can adapt it to families of youth quite easily. And if not, it's very feasible to implement still. So we'll start by going through the case of Mr. George Wilkins.
All right. So we have a couple of different samples. So this one's sort of an adult population, and I did engage one of our fabulous audience members to be George Wilkins for us. So I guess what we could do is, I don't know if, Christian, you want to come sit next to me, and we can just pretend to be George. Yeah, or I'll come over here. Okay. So, all right. So it looks like, George is a 61-year-old male. He has a history of PTSD, depression, substance disorder. He's coming to me at Grady Memorial Hospital, middle of the night, Atlanta, kind of intoxicated. His son's out in the waiting room. He's been pretty depressed lately. And so I was going to try to simulate this conversation just so you guys can see how to use some of the techniques in real life to apply in your settings. So Mr. Wilkins, how are you doing tonight? Thank you so much for being here with me, and Christian too. Yeah. How are you feeling? I know not so great.
I'm feeling okay.
Yeah, okay. Okay, your son was pretty worried about you. He said you've been pretty depressed lately, not doing so great at home. I know your wife recently left, it sounds like, and you've been drinking a lot. Does that sound about right?
Yeah, I don't really like to talk about those things with doctors sometimes. But
I know it. I know you find yourself, I know you don't want to be here tonight. I'm so sorry. Yeah. So, I was thinking, the mental health clinician had come by and they'd said, it sounds like you're not thinking about hurting yourself right now. Is that right?
Nah.
Yeah. Had you thought about it in the past?
Maybe sometimes.
Maybe sometimes. Okay. And your son told me a few minutes ago, you're an Army guy, you've got a lot of, veterans you hang with and all that.
Vietnam.
Yeah, Vietnam. Awesome. Yeah, that's great. And so, one thing I'm concerned about, especially given your current state, it seems like you're going through something right now. You're definitely having a hard time. Would you agree with that?
I think things haven't been great.
Yeah,
I'd say that.
I know it.
I mean, I'm sitting here in the emergency room with you.
Totally.
Not going well.
I completely get that. I completely get that. So one thing I wanted to talk about is just some ideas to maybe keep you safe. Would it be okay to ask you some more questions about that?
Do whatever you need to do, Doc.
Yeah, let's do it. Okay, so, I know it sounds like you probably have, a handgun or two, maybe a rifle. Would you say you've got some, how are you storing your firearms right now?
Well, I've got the standard one by the bedside.
Got it.
You know?
And that's your handgun, or what's?
Yeah, it's a handgun.
Got it.
And then my son and I occasionally go hunting, so we got a rifle.
Got it.
In the house. Yeah, that's it though.
Yeah, all right. And usually use your handgun. What would you say you own that one for? Is it just to have around, or what do you? What would you say?
Yeah, I don't know. It's like an old Army habit. Like just like protection and protect the family.
Yeah.
I'm living with my son, and I feel like I've always had it.
Yeah,
so.
it's sort of like an extension of you. I've had some folks say that too. It's really a big part about their identity and whatnot. It's one thing. So I imagine you probably store it by your bedside table. Is that right? Mm-hmm. Okay. Is it? Do you have any locking devices for it? Is it just kind of in the drawer? What would you say?
No, it's in the drawer. Right. Given that what I was going to use it for.
Yeah.
Just keep it there.
Just in case
Yeah.
if someone comes in to rob or that kind of thing, or what do you?
Yeah.
Yeah, mostly that. Okay. Have you been robbed before? Has anyone broken in?
No.
Yeah. Well, okay, well, that's good. It's good to help us kind of think about that in this context. So, one thing I'd love to think about, especially since you're going through some, crisis right now, is thinking about maybe securing that firearm a little differently. Would that be something you're maybe open to, or what would you think about that?
Well.
Just right now, while you're having this trouble.
My son doesn't like it there.
Yeah, I know. And so I was thinking it may
before.
be great. He's outside. I'd love to invite him into this conversation. Would you be open to him? I know he knows about what's going on. So maybe it'd be great if he came and talked to us and think about some of this together. Would that be something you're open to?
Well, yeah. I got to have a place to live.
Indeed.
So
okay.
I think he might be.
Great. Okay. Well, that's a great start. Okay. Well, thank you. Thank you so much, Mr. Wilkins. I just want to stop it so we can do that. Yes, you're amazing. All right. So that's just a demonstration of how to just kind of get into the conversation, especially with our adults and our veterans. They're very much extensions of their own identity. So I've even gone so far as to talk to some of the veterans about lining the gun safes with pictures of their families, things to help them remind that this is being a firearm owner is important to them, but their life and their family, and really trying to very much nuance it and individualize the counseling as much as you can to help them be safe. All right, so the next case, yeah.
So next we'll be discussing the case of Wyatt Dixon, who is presenting after a fight at school.
Okay, so we're going to role play with Bijan being the mom. So I'll give you guys a little bit of background. So I'm in the ER today. I'm seeing Wyatt Dixon. So he's a 16-year-old that comes into the ER after getting into a fight at school. And mom had earlier told me that he's been more moody, his grades have been dropping, and that he's just been getting angry all the time. His grandfather has recently passed away, and that had been somebody that he'd been closer to, and he also recently broke up with his girlfriend. So I went into the room earlier, I tried talking to Wyatt. He's not interested, thinks that this whole thing is stupid, that he's here. He says he's totally fine, he's not wanting to talk to me. So now I'm going in and talking to his mom. Hey, how are you doing, Ms. Wyatt?
Doing well. How are you?
So what brings you guys into our ER today?
He just injured his foot when he was playing with his new rifle recently, but I hear it's going to be fine, so I'm not too worried.
Yeah, so it looks like the injury is going to be something that we can take care of. We had took some x-rays, nothing's broken, and we should be able to get it cleaned up and, get him to follow up with his pediatrician to take another look at that wound.
Wonderful.
Is there anything else going on that you want to talk about with me today in terms of him having the firearm at home? Has Wyatt used the firearm before?
Oh yeah, he's been trained since he was really young. He goes out hunting with his dad all the time. We taught him all the safety techniques and everything, so he's well versed.
That's really great. So it sounds like he's had prior safety training with the firearm?
Yep, lots of safety training.
Is it okay if I offer some advice related to how we recommend firearms be stored in homes with children and teens?
Yeah, as long as you don't tell me to take it out of my house.
Okay, I respect that. So we know that children and teenagers especially can sometimes be impulsive, and although I think it's really great that Wyatt has prior firearm safety training, have you all ever thought about how you store your firearms now that he's going to high school? And I know that you mentioned that he's had a lot of changes recently in the household. I'm really sorry to hear about his grandfather.
Yeah, so we have a big gun cabinet in our house, but the only people that know the combination are me and Dad and Wyatt. The younger kids don't know the combo.
Okay. And have you all ever considered just keeping a private combination for you and your husband?
No, because Wyatt's a real level-headed guy, so and one of his guns is in there, so we wanted him to have access to it.
Okay, that makes sense. I think I completely respect where you're coming from, and that in the past that Wyatt has been responsible and has been taught how to use guns safely. The one thing that I just wanted to kind of bring up is that what we see in teenagers and how they're different than adults that own firearms is that things can change really quickly. We know that he's going through a lot of challenging circumstances right now with his grandfather passing away and recently breaking up with his girlfriend, and that although he seems stable at that time, right now, that may change. And so one of the things that I always like to recommend to parents that come in with their child that may be going through acute changes with what's going on with their emotions is to do something that can ensure that they don't take action quickly. We know that most teenagers will go, although he's stable and not saying that he wants to hurt himself right now, that can potentially change, and that most teenagers will go about thinking about wanting to hurt themselves to acting upon it within an hour. And in that time, you may not be able to get to something like a firearm.
Are you saying that my kid is gonna, commit suicide? Because he's not one of those. It's like a really rare thing. I don't think my kid would do that.
And I hope that we never have that conversation, and that that he continues to say well. And I will tell you that most parents that have had children that have died of suicide, there's not been any warning signs for them. And so what we recommend is that strategies for just taking action and ownership early on and keeping things that potentially could be dangerous in the home away and out of reach while he's going through lots of changes in his life. So not only, keeping the firearm code separate from what he would know, but also keeping medications, if there's any medicines that you or his dad or any family members take, keeping them locked and
Like all the prescriptions?
Like all the prescriptions.
Okay.
How do you feel about that? Is that something you'd want to start thinking about?
I think that's reasonable,
Okay.
based on what you're saying about how impulsive kids are and stuff, I guess.
Thank you for listening, and I'm happy to talk further.
Wonderful. Awesome.
So that just gives you an idea. I mean, this is typically what I come across in the ER in Atlanta. Most of the parents are gun owners. Most of their kids have been trained to shoot at a very young age. They are hunting families. And a lot of them have been gifted rifles. They don't physically own them, but a lot of their teens may have them as a family heirloom or it's been passed down. And so bridging that gap, Bijan or Miss Wyatt came in, not really wanting to talk about keeping the firearm outside of the home, and so I usually don't start there. I try to talk about, what could be the risks of let's talk about what else may be going on at home. And highlighted here that there were some circumstances in the family that could be troubling to Wyatt, and his mood may change quickly, and then he may become impulsive, even though he hasn't in the past. And so bridging that gap to where, they want to meet you. Bijan had already told me earlier on that he's not going to keep that firearm out of the house. And so accepting that and meeting them where they are is some of the strategies that we use.
Awesome. So we'll try to wrap up respectful of everyone's time here. So hope to leave you with a few key take-home points. So youth suicide, unfortunately, continues to rise, as does suicidal ideation, and that is mirrored in the amount of ED visits that are coming to both pediatric EDs and general emergency departments. Lethal means counseling is evidence-based and is helpful in preventing suicide in both youth as well as adults. Firearms, and we're not anti-gun, but we're just pro-safety. So firearms are the most lethal means and have the highest case fatality rate of any modality of suicide attempt by far. Working with families, whether it's an adult or a child, working with the families using a harm reduction strategy is key. If they're not going to be agreeable to do triple safe storage or store it off-site, just working with them to help do a biometric lock, but they keep it loaded. Some safety measures are better than no safety measures. And lastly, we hope that you'll utilize some of the freely available resources that are available online that you can, as Sue mentioned, like put a QR code and some discharge paperwork, provide some links to families, because these are there's lots of great resources for both family members as well as clinicians. So thank you so much for your time. We'll now take a few questions if anyone has any. Thank you. Yes, go ahead.
This was very helpful and practical as well for those of us that take care of adolescents. I was curious where, because since you're the experts in this, where the research side of this stands in terms of you've laid out a nice evidence base for what is effective and what is the risk, and from so I'm curious where it stands in terms of from an implementation science point. Are there studies being planned to, in a multi-center fashion, to evaluate what are the barriers and facilitators to actually implementing some of these evidence-based strategies that you've shared? Because I think that's very much needed to really, most kids aren't seen in children's hospitals and general EDs, and so we know how to best implement this on a broad scale so that it can be effective and truly reduce mortality. What are your thoughts on that?
Yeah, so I think there's definitely some limitations in the sense that, at least to my knowledge, there has not been any large multi-center studies that have been conducted at the moment. That is sort of on the docket for several different key venues. One of them being the American Academy of Pediatrics has a improving mental health care in the acute care setting. And that is a national QI collaborative that kicked off actually this month. And so even though it's been in the planning stages for a while, and one of the 4 key measures that they are looking at is improving the documentation of lethal means counseling and the receipt of lethal means counseling for families. Now, the limitation for that is obviously focused on pediatric settings, and so we definitely want to incorporate some of our adult-focused colleagues as well, and so that's why we wanted to present this here today, and form some partnerships going forward. From an implementation standpoint, I think one of the key barriers to having a multi-site study is just the ability, the different geopolitical environments and the questions that you are able to ask and what your patients and their families will be willing to answer. So Neil Usball, in the study that Sophia mentioned earlier, was able to ask families, how many guns do you own? How are each of them stored? How is your ammunition stored? I tried to conduct a very similar study in Ohio, and people said, stop asking me questions, and that was that. Neil was in Seattle for their study. So what I had to adapt our verbiage to in Cincinnati when I was training there was, are all the guns in your home locked? Yes or no? And families were willing, after much piloting, were willing to answer that question, but they weren't willing to disclose like how many guns, et cetera. So I do think whether you're practicing in Texas, Minnesota, Florida, California, how you go about asking those questions might be slightly different, but hopefully we are working and getting closer to a point where we can have some degree of universality to how we approach this and how we can implement it in both the pediatric and general ED setting. Does that answer your question?
Yeah, so I also brought it up, I brought it up because PCARN, PCARN has the funder, HRSA, has prioritized implementation science. So implementation science is a priority for PCARN, at least for the next 3.5 years, to the mission of emergency medical services for children that funds PCARN is to decrease morbidity and mortality for children. This is the leading cause of death in that age group, right? So I think this is a high priority issue, needs to be studied in a multi-center fashion for the reasons that you said as well. That there are geographic nuances of how to best approach this, and I think that doing it from an implementation science point of view will be helpful to make it generalizable.
Certainly.
In diverse locations across the country.
Right.
So there is
Certainly.
a PCARN mental health work group, which is always looking for members, and right now is setting a research agenda. And that is definitely top on the agenda, is implementation of best practices. I think, as Bijan said, there's many single sites and studies, but there hasn't been any sort of PCARN level multi-site study. So that is, I think, a step along that way.
I also think like some of the interventions are so different, like counseling alone. Do you provide a safe lockbox? Like there's so much nuance in this space that it's sometimes hard to have, multi-site studies where we'll have each interventionalist being the same. And so there's still, and then what is a safe change? Is it like up in, so we have there's a lot of work being done in what safe storage looks like. Because as you can see, bedside table unlocked versus out of the house versus in a thing. There's so much nuance in that. We're trying to figure out how, a lot of the research in this space are trying to think about how to quantify safety and how to think about how you store and what that means in terms of risk conference of injury or death later down the road. So that's definitely a work in progress. So what a great question. Thanks. Yeah.
So thanks for that question. We are actually in our site in Atlanta. That's our next step, but it is still a single site. So I welcome partnering with other groups. Our next steps are for widespread implementation in all 3 of our pediatric EDs, looking at it with an implementation science framework. I will say one of the other big gaps in this work is that we don't have a lot of data. So not only the qualitative understanding of barriers and facilitators, but also the longevity of if this treatment's effective over time, right? So a lot of the studies that I shared, they're just, due to the nature of the study and capacity, the follow-up periods are much shorter. And so how long has this adaptation lasted after the intervention is something else that I think is another gap.
Thank you again, everyone. Appreciate you all.
Thanks, everyone, for coming.